Diagnostic criteria for migraine headache. A high index of suspicion is required to diagnose migraine. The migraine aura, consisting of visual disturbances with flashing lights or zigzag lines moving across the visual field or of other neurologic symptoms, is reported in only 20 to 25% of patients. It should be distinguished from the pan-field television static-like disturbance now recognized as the visual snow syndrome. The first phase of a migraine attack for most patients is the premonitory, prodromal, phase consisting of some or all of the following: yawning, tiredness, cognitive dysfunction, mood change, neck discomfort, polyuria, and food cravings. This can last from a few hours to days. Typically, the headache phase follows with its associated features, such as nausea, photophobia, and phonophobia as well as allodynia. When questioned, these typical migraine symptoms also emerge in the premonitory phase, and typical premonitory symptoms also continue into the headache phase. As the headache lessens, many patients enter a postdrome, most commonly feeling tired/weary, having problems concentrating, and experiencing mild neck discomfort that can last for hours and sometimes up to a day. A headache diary can often be helpful in making the diagnosis. This is also helpful in assessing disability and the frequency of treatment for acute attacks. Patients with episodes of migraine on 8 or more days per month and with at least 15 total days of headache per month are considered to have chronic migraine. Migraine must be differentiated from TTH, which is reported to be the most common primary headache syndrome. Migraine has several forms. Migraine with and without aura and chronic migraine are the most important. Migraine at its most basic level is headache with associated features, and tension-type headache is headache that is featureless. Most patients with disabling headache probably have migraine. Patients with acephalgic migraine experience recurrent neurologic symptoms, often with nausea or vomiting, but with little or no headache. Vertigo can be prominent. It has been estimated that 1/3 of patients referred for vertigo or dizziness have a primary diagnosis of migraine. Migraine aura can have prominent brainstem symptoms, and the terms basilar artery and basilar type migraine have now been replaced by migraine with brainstem aura. Migraine, the second most common cause of headache, and the most common headache-related, and indeed neurologic, cause of disability in the world, afflicts 15% of women and 6% of men over a 1-year period. It is usually an episodic headache associated with certain features such as sensitivity to light, sound, or movement. Nausea and vomiting often accompany the headache. A useful description of migraine is a recurring syndrome of headache associated with other symptoms of neurologic dysfunction in varying admixtures. A migraine attack has 3 phases: premonitory, prodrome, headache phase, and postdrome. Each has distinct and sometimes disabling symptoms. About 20 to 25% of migraine patients have a 4th, aura, phase. Migraine can often be recognized by its activators, referred to as triggers. Migraineurs are particularly sensitive to environmental and sensory stimuli. Migraine-prone patients do not habituate easily to sensory stimuli. This sensitivity is amplified in females during the menstrual cycle. Headache can be initiated or amplified by various triggers, including glare, bright lights, sounds, or other types of afferent stimulation, hunger, letdown from stress, physical exertion, stormy weather or barometric pressure changes, hormonal fluctuations during menses, lack of or excess sleep, and alcohol or other chemical stimulation, such as with nitrates. Knowledge of a patient's susceptibility to specific triggers can be useful in management strategies involving lifestyle adjustments, although it is becoming recognized that some apparent triggers may in fact be part of the initial phase of the attack, i.e., the premonitory phase or prodrome.